Okay, so let's talk about a case. This is a case that I was involved with several years ago that I love. She's a 24-year-old woman. She's a basketball player on scholarship. And she's been permanently sidelined because she has osteoarthritis in both of her knees. She's had 5 arthroscopic surgeries so far. And she realizes that she's really not going to be able to play basketball. That's what she wanted to do. She wanted to do this for as many years as she could do it, and so now she's hoping to find a career in coaching. Which, incidentally, when I talk to my orthopedic friends, every athlete who gets permanently sidelined from an injury wants to be a coach or a sports management person. It's kind of like there's not enough room for all these people to do it. So she needs bilateral, she's 24, she needs bilateral knee replacements at 24 because she has chronic pain and she has deteriorating function. She comes to see us because she's got an alcohol problem. She's drinking very heavily. She's getting into trouble. And I get involved with her. So, what we do in medicine, oftentimes we come up with what's called a problem list. And a problem list is a very pragmatic way of listing what needs to be addressed, right? Somebody's in treatment. So here's the problem list that I came up with when she first came into treatment. She has osteoarthritis of her knees. We know that. She has an alcohol use disorder, okay? She has a chronic pain disorder. So chronic pain disorder became a diagnosis in the ICD-9 classification of diseases. In the Institute of Medicine, has written extensively saying that chronic pain is a disease in and of itself that needs to be addressed. It's not just secondary to the, in this case, arthritis. It's a disorder all its own. And she very much had the emotional dimension of pain. She was very anxious, she was angry, she's frustrated, she's depressed. She's a mess, right? And that's why she's drinking. She didn't particularly want to come into treatment because this was her medicine for all this emotional pain. It was the alcohol. So the question I love to pose, and I teach pain fellows. These are anesthesiologists who are going to go into pain medicine. I say, what do you think will happen if you put this person on chronic opioid therapy? What's the likely outcome? It's one of my test questions, right? And here's my list. Well, she's very likely to get what's called opioid-induced hyperalgesia. For those of you who don't know what that is, opioid-induced hyperalgesia is a state where the person on opioid painkillers feels more pain from the same stimuli as the person who's not on opioids. And it happens in the literature, and I think the pharmaceutical companies will admit to about 30% of people may get this. I'm going to say it's 70 or more, all right? People on long-term opioids will get this hyperalgesia, greater pain. She also is very likely to delay her rehabilitation. It's, if she gets on opioids and starts to feel a little bit more comfortable, and I mean that in an emotional sense, not in a physical sense, it's going to be less likely that she's going to pursue a rigorous course of physical therapy and get herself back on her feet, so to speak, okay? Because she's somewhat sedated, she's somewhat appeased by the opioids on a long-term basis. She's very likely to develop an opioid use disorder. She doesn't have an opioid use disorder right now, but she has an alcohol use disorder, and we know that introduction of another abusable drug into her regimen is very likely to cause problems. She also, this is a 24-year-old who spent her whole life in athletics, and her career is dashed. And she has to grieve that. She is not going to be an athlete. She might be an agent, a sports management agent or a coach, but she might not. And she needs to grieve that. And grieving when you're on opioids does not happen very easily. It's kind of like, why do I need to grieve? Give me another pill. And she's going to procrastinate looking at other career opportunities, which she needs to. She's 24, she's in school, she's got a career counselor available to her. This is when she needs to do this work if she wants to move on with her life. So prescribing opioids could lead to all this. It's not a great option in my opinion. And she's going to start to get isolated because of all this other stuff, because her family and friends are going to all say, you need to do this and you need to start doing this. And she says, yeah, I know, I'll get to it. Yes?
Component of her profile that puts her at increased risk for the opioid-induced hyperalgesia? Is it psychosocial variables that predict that sort of thing? Or?
No, it's probably pharmacogenetic. That's my guess. There's some research that suggests that certain variants of the mu-opioid receptor formation have to do with that. It's not, we don't know. But it's much more common than most people believe it is. And there's no way to know, when somebody crosses the line. But it happens generally in people who've been on opioids for 3 months or more. Yeah. So what does this person need? That's my next question. Well, there's a lot of things she needs. First, she needs surgery and postoperative pain management. She's got to get these knees replaced and start to rehabilitate herself. She needs addiction treatment because she's got an alcohol use disorder. Alcohol is her drug of choice, but opioids, if she gets on opioids, believe me, they're going to be her drug of choice before long. She needs an addiction-savvy primary care doctor who can guide her through all this stuff so she can, make the right choices and move within a reasonable timeline. She also needs addiction specialty care. She needs an addiction therapist, a counselor. She needs somebody who can kind of guide her as a friend and suffer with her, honestly, hold her hand through all this crap. It's bad. She needs career counseling. She needs psychosocial and spiritual support. This is devastating. This is just, if you really dig into this, this young woman has got some significant problems. All right. So she was in our facility, and once we got her through alcohol withdrawal and kind of got her into feeling some positivity about her life and some optimism, we discharged her. I discharged her to her orthopedic surgeon. I said, go have your surgery now. Do your post-op couple days, come back to me, let me manage your post-op pain, and we'll get your rehab started, okay? Now, this is a story. I talked to her orthopedic surgeon, and I said, this young woman, I'm seeing her because of alcohol, and blah, blah. Oh, yeah, I know her. I know the whole family, and I've operated on her, blah, blah, blah. And I said, well, tell me, she needs these knee replacements. She wants to have one done. How long do you usually prescribe Percocet afterward? Because this is an acute pain episode, right? If she needs an opioid, I want her to have an opioid. I'm not going to say, no, you can't have it. How long do you usually keep them on? He says, usually about 4 weeks, no more than 4 weeks. And I thought, 4 weeks? I was a surgeon. 4 weeks? Are you kidding me? That's just unrealistic, A week and a half? Yeah, we might be there. Anyway. But that's treatment as usual. There's not much differentiation for somebody who's got a substance use disorder who's recovering from somewhere else. Yes?
You had that discussion with him?
I said, what I asked him, I said, are you opposed to me using a different opioid analgesic for her if it gives her adequate pain relief besides oxycodone? And he said, no, what did you have in mind? And I said, well, buprenorphine has some great analgesic properties, and in this scenario is probably a better option for her. Well, he wasn't very familiar with buprenorphine. He thought it was only a maintenance drug for addiction. And so he said, sure, go ahead and do that, right? So we discharged her. She had surgery. She returned 2 days post-op. She did get some Percocet during her post-op period. And then when she came to us, she brought a prescription for, a zillion Percocet tablets, when she came to see me. And I said, here's what we're going to do. We're going to let this wash out of your system. I'm going to give you some Toradol injections. Toralac is a very potent non-steroidal agent. And I let this medication wash out of her system, and I was able to treat her with buprenorphine. Now, buprenorphine has great analgesic properties, but it's not particularly rewarding. It doesn't make people feel high for the most part, okay? After 2 days, she didn't need that anymore. She just didn't need any opiates after. That was surprising even to me. I thought she didn't need it for at least a week or a week and a half. But I was able to get her back on non-steroidal agents. She was fine. It didn't dysregulate her brain. She didn't get her into that addiction mode, that relapse mode. She started physical therapy, and we started doing, at the time we didn't have physical therapy on our campus, but we had a practice nearby, and she went and she was able to resume her physical therapy. 2 weeks after surgery, how's your pain? She says, it's about a 2 or 3. I feel better than I have for a long time. Boom. She's now able to engage in treatment, start planning the next steps, and it's kind of like this surgery was a major, major speed bump, potentially, for her recovery, and she was able to get through it. So I just consider that, that's ideal. If you can do that, it works. Yes?
How does she feel about stopping her alcohol drinking? How is she going to, manage that, and what does she need to do to make sure that doesn't recur?
Right. So, when she first came into treatment, before she went out for surgery, I'm going to say she went out for surgery probably 10 to 14 days into treatment. The treatment stay at our facility is anywhere from 28 days to who knows how long, 4 months sometimes. And generally, if a person comes into treatment and they have a substance use disorder and a chronic pain disorder simultaneously, I usually recommend 6 weeks. And I give them lots of reasons why. So before we even addressed this, she was very much engaged in her alcohol treatment. She was working with her counselor, and her counselor was able to show her, look at the problems that this is. She had, I don't know if she had a DUI. She had some run-in with the law. I'm not sure if it was a DUI or drunk in public, or she had something that was just kind of a shocker to her and her whole family. And once this was pointed out to her, look what this is doing for you. And we started to show her how this was affecting her negatively, and how it was non-productive in terms of her future. She bought into it. She didn't want to drink anymore. So she was pretty engaged in treatment from that respect. Yes?
What were you using for initial pain control during that, or for pain control during that initial period where you were focusing on the alcohol before the surgery?
She was just using naproxen, naproxen, and then ice. She was icing on a regular basis, elevation. She wasn't weight bearing. We had her doing all these things, and she was okay with that. Yeah. I think the biggest component of her pain preoperatively was knowing that she needed to have this surgery done, and that's, anxiety and that kind of apprehension will increase a pain condition. We know that, and I'll talk about that. So you all who are substance abuse professionals may be saying, well, how do I help somebody who has chronic pain? How can I help? There's medicine and physical therapy and rehab and all this stuff. What can I do? When I heard about this conference, I was told a long time ago that this group was very much interested in how 12-step principles of recovery are still, what do I want to say, relevant. In today's world, 12-step recovery is kind of old. It's old school. It's not terribly relevant. And my experience is that 12-step recovery is extraordinarily helpful and extraordinarily relevant in chronic pain patients. As a matter of fact, many of you may know that there is a 12-step program called Chronic Pain Anonymous, just for people with chronic pain and chronic illness. And it applies the 12 steps to coping and dealing with these things, whether or not somebody has a substance use problem. I'm fortunate enough to have a Chronic Pain Anonymous group in our area, and my patients get to go to this meeting, and it's really, so I want to talk about applying 12-step principles to chronic pain management. And the reason why I want to do this is because this is something that anybody who's helping somebody with their addiction issue can do. There's handouts, and because what I did is I created a list of questions that I have found myself over the years challenging people to answer for themselves, that with respect to their pain, right, that are absolutely applicable to their recovery from their substances. I run a group And I meet with all these people individually for psychotherapy in addition to prescribing. And I found that if I can get people to start answering these questions for themselves, the progress that they make is astounding. So what I've listed here are enough to last. I can guarantee you, if you can get your patients that have substance use disorder and chronic pain starting to work on some of this stuff, there's a lifetime of stuff here, all right? So these are the principles behind the 12 steps for those of you who don't know them. And all the steps have these certain principles of behavior and thought, and we're going to go through each one, and I want to show you how these things can be useful for managing chronic pain patients. So step one is honesty, right? We admitted we were powerless over alcohol or whatever the drug was, and our life had become unmanageable. So how does this apply to pain? Well, one of the things I start to ask people is, how has this pain started to dominate your life? Have you become your pain? Have you become the pain, the girl that has the pain in her knees? And we see that all the time. Is my pain truly a 12 over 10 when the scale is 0 to 10? You know, I see this all the time. All right, so 0 means you have no pain. 10 means you're about to pass out unconscious because your pain is so bad. Where are you in that scale? Oh, I'm a 15. You're conscious. The scale goes from 0, right? I have to explain it again. Oh, I'm a 12. Really? How can you be a 12? Is my pain really a 12? I asked them to answer.
Mine was at 24 when I had peritonitis.
Right, 24, that's right.
Just shaking.
On any, well, that's right. I mean, you're about to pass out, and that's,
Rolling on the floor. After
Right.
My husband was shaking.
and that's legitimate. That's exactly right. You're right. Death would be preferable to this. Now, that's not what we see with many of these patients, you know. Am I thoroughly honest with my healthcare providers? Am I telling them what I'm doing, how the medicine's working? And the answer to this is probably 100% of the time no, right? If somebody has a substance use disorder. Do my pain pills really help me, or do they just stave off withdrawal syndromes, right? These are huge questions for people to start working on. Step 2, the principle is hope. This is came to believe that a power greater than ourselves could restore us to sanity. Well, what level of pain is realistic? Well, what can I expect? You know, what's my best, I say this, what's my best case scenario? Given my condition, you know, is 3 over 10 an unrealistic expectation, or is that okay? What level of pain can I live with? I ask people this all the time. I was like, okay, 0 out of 10 is not practical. What can you live with? And eventually they'll tell me, if I'm at a 7 now, if I could get to a 4, I'd be okay. 4 is it. That's your goal. We're going to get you to a 4, I promise you. How do I wish my relationships were different? This is one of the things that both addiction and chronic pain affect tremendously. My relationships with my family. Is it my children, my spouse, my parents, my friends? And what's my best case scenario, as I mentioned earlier? Step 3, made a decision to turn our will and our lives over to the care of God as we understood Him. This is surrender. This is having faith, right? Can I ask others to help me with my activities of daily living? How much does it affect my ego to have to ask for help? Can I tolerate a short-term increase in pain in order to achieve lasting long-term improvement? This is a question that I always put to people before I start to detox them off their opiates, okay? Do I have a higher power? This is a huge one. This will show up more and more and more here. And I'm not going to go through this in great detail, but I just want to I hope to just put forth the message that these principles will help people with pain. Do I dare ask a higher power for relief of pain? Can I pray for it? Can I pray for rest, for sleep? Step 4, the principle is courage. This is, made a searching and fearless moral inventory of ourselves. So I ask people, how have I mistreated myself and others when I've been hurting? How do I act out? How am I cranky and crabby and mean? How have I used my illness to realize self-centered gains? We run a group once a month where we talk about what have you gained as a result of your chronic pain. People walk in there, they're so offended. What do you mean gained? Are you kidding me? I've lost everything. By the end of our session, yep, I get lots of pity. I don't have to cook a meal. I don't have to do nothing. There you go, right? It works. What still feels good about me? You know, part of the inventory that people take in 12 steps is what's okay about me. So I specifically use these words. What still feels good about me? And it's astounding when people start to get some insight into actually how they're feeling, things start to move, okay? Integrity, this is step 5. How has my reaction to my pain come to change who I am, right? You know, because it's not the pain, it's how we react to the pain that bothers us. How much of my pain is emotional pain? And this is a huge one. This is always different for everybody, you know. There's some suggestion in the medical literature that almost all of it is at some point, right? Do I notice incremental improvement in my pain when I start to get honest? And I see this all the time. This is one of the most important things that I see. Willingness. Am I willing to give up my pain patient role? Pain patient role is very comfortable, right? Am I willing to change my expectations of myself and others? Am I willing to take an active role in my own pain management? The next step is humility. Am I able to humble myself before the world and just meet life as it comes? In other words, am I able to change my expectations of what my life is going to be? You know, if I'm a 24-year-old athlete and can I become willing to accept that I'm not going to be an athlete ever again? You know, that's very hard. Next is, can I ask a higher power to help me do that? Next, when I ask, why did this have to happen to me? And please help me. Who am I speaking to? This is, again, a higher power issue. Who am I asking that of? Whatever people answer, that's your higher power, right? Who am I asking for help? Brotherly love. Can I allow others their own suffering and allow myself a right amount of suffering? I've had patients get so mad because they say, that person in group, that person, they don't even know what pain is. You know, they just have this little, you name the injury. But my injury is, and I say to them, can't you allow them to have their own suffering? You have your suffering, they have their suffering. It's fine. You know, one of my basic principles is, if you say you have pain, you have pain. You know, that's fine. You have pain. Pain is subjective completely. Okay, let's see what we can do about it. You have pain, fine. If your pain is really severe, fine. We'll treat it as if it's really severe. But that doesn't necessarily mean we're going to give you drugs for that pain. Next, can I accept the help and amends of others? Right? Very tough. Next principle is justice. What amends to others are called for? What amends do I need to make for myself? That means self-care. You know, how do I take care of myself? How do I set limits on my goals and activities? Next, step 10, this is continue to take personal inventory, and when wrong, promptly admit it. It says in the Big Book of Alcoholics Anonymous, this is not an overnight matter. It should continue for a lifetime. This is a new way of life for people to adopt. Spiritual awareness, probably my biggest emphasis in these principles. Do I detect the presence of a higher power? Can I feel that higher power within myself? We use a lot of mind-body practices, a body scan, things like that help with chronic pain. And what they do is they increase awareness. A lot of people are very resistant to doing this work initially because it's like, don't tell me to concentrate on my body because then it makes my pain hurt. And when people start to do that, then they start to actually develop what I call peaceful coexistence with their own body. And it's part of the 11th step. How do I stay mindful of my body movement sensation and not be judgmental about it, not say it's bad? It just is. When I feel discomfort, is it because of my pain? Is it because of craving? Or is it because I'm depressed? And what's occurring with my body? So this constant awareness and mindfulness about the body. And then as far as service goes, step 12, can I offer support and encouragement to family, friends, and other pain sufferers? The chronic pain group is one of the most beneficial things I've ever experienced. It's unbelievable. People don't want to talk about their pain because they think, well, my family's so sick of hearing about it. But when they're sitting with other people that have chronic pain, they get it, they all get it. Am I doing all I can to get to meetings, appointments, and speak out about what it used to be like and what's now? So You know, take this stuff. If you can apply one question to one of your chronic pain patients and get them to start to open up about it, you'll be doing them an enormous favor. It's incredible what happens. All right, so let's finish this off with a case, because as I said, I love cases. So this was a 51-year-old. He had degenerative disc disease in his cervical spine. He had had a multi-level discectomy and then had prosthetic discs put into his back, into his neck 5 years prior to admission. He had chronic neck pain and initially had OxyContin and immediate release oxycodone plus morphine for a couple of years before he had the surgery. Then he had the surgery. But he couldn't get off the pain medication, right? The surgery was successful, but he continued to have postoperative pain, and they couldn't get him off the pain medication. So when he came to see me 5 years later, this is what he was taking. Now, you don't have to be a medical person to know this is a lot. This is a lot. This is a lethal amount of opioids that he was putting in his body every day of his life. Oh, this is this thing I got today. I didn't know it talked to me. Sorry. Right, so it's like, whew, okay, got my work cut out for me. He had been in 6 previous addiction treatment episodes. His drugs of choice were opiates and cocaine, heroin and cocaine. He's working in the industry, right? And his chief complaint when he came to see me was this: I'm here to bring my medication down to an acceptable level so that I do not seem impaired. He had no belief that he was impaired, but other people were saying, you seem impaired. So he came in just for an evaluation. He didn't want treatment. He just wanted to be, and he was hoping maybe we could decrease the doses of some of these things just a little bit so his speech wasn't so slurred and he had a little bit more bounce in his step, right? So I'm, you know, everybody's looking at me. What are you going to do? You know, it's like, this is the time when I used to say, call Ghostbusters, you know? But the answer to this question is, well, we have to meet this guy where he is. So let me go through his problem list. He's got an opioid use disorder, very severe. He has a sedative hypnotic use disorder that's very severe. He has chronic neck pain. He has terrible psychosocial support. Nobody, you know, his job doesn't want him there. His family is kind of like, go away, get better, come back home. He's very afraid. He can't imagine that he could get off of these medications. He's completely convinced he must have these medications or he will not be able to function at all. He's very afraid of stopping these drugs. He's been in 6 treatments before. He's detoxed multiple times, and it's tough. He's a ball of fear. So we started our magic. Buprenorphine, 16 milligrams a day, phenobarbital 4 times a day to kind of facilitate weaning him. We got him off of everything in a little bit over 3 weeks. It was not easy. It was not easy. We used Toradol for his neck pain, comfort medications, but what I brought to bear with him was a lot of alternative treatments. And I have the blessing of having an incredible staff that can bring these things to life. He was getting acupuncture a couple times a week, very afraid of it at first. He was like the biggest advertiser for acupuncture when we was done that you ever saw. He was like, oh my God, it's a miracle. It's unbelievable how much it's helping me, twice a week. He was getting medical massages a couple times a week. That was helping with relaxation as well as with the pain. He's getting physical therapy a couple of times a week. He got an individualized fitness plan, which meant just starting to move a little bit. He started doing yoga, and this guy, when he left treatment, he said the most important thing in his life was the thing he looked forward to most was his next yoga. Unbelievable. So the support was crucial. Family involvement, individual and group substance use psychotherapy, individual and group chronic pain psychotherapy, very specific, spiritual intervention. So this guy had some periods of recovery. He was very spiritually oriented in the past when he was sober. And, you know, he actually missed that. Once we started to kind of facilitate him getting involved in that again, it was amazing how much this guy missed that and how important it was for him. And then, of course, he had been an active member of NA, Narcotics Anonymous, and we got him back involved with that. But all of these programs, he was eligible for any one of these programs. So I just want to point out some highlights of his progress as we finish up here. On day 2, his family, he wanted to come in, be assessed, and then leave. And his family said, no, you can't do that. You have to stay in treatment. By day 9, he was reported as having an amazing experience. An amazing experience. Well, what does that mean? What does that mean? In 12-step lingo, what we're starting to see here is somebody who is having a spiritual awakening. That's one of the ways we see that. He couldn't describe it. It was amazing. I think that acupuncture did something. That's the way he put it. It was an amazing experience, right? So now he started to be confident. I don't have to take these medicines. As a matter of fact, that same day, a couple weeks later, he said, I'm not feeling anxious, and I'm not thinking that I need a medicine to feel any better. This is 3 weeks after initiating this. 3 weeks, all right? And this is it. His recovery is starting. He's starting to recover at this point. That same day, he called his previous pain management doctor who was giving him that boatload of medications. He said, I'm not going to be coming back. We asked him, do you think you want to do that? He said, absolutely. I'm not going to be needing your services anymore. Right? By day 35, he's taking no medications at all after 7.5 years of of opioids. Takes occasional ibuprofen, but man, he wants yoga. He wants to do yoga. He wants acupuncture. And this guy, by day 35, this guy started to sound like somebody that's been in recovery for 6 months to a year. You know what I mean? He had the right motivation. He was talking to other people. He'd come to group and he'd tell people as they're walking in the door, he'd say, I was way worse than you when I came in, and look at me, I'm feeling great. And it's just amazing to watch. So at Karen, let me just give you a little bit of data here. We have obtained data on 283 patients with chronic pain conditions at Karen since September of 2012 and June of 2016. And we've treated a lot more than that, but these are the ones that we've gotten data on. Our data collection is not ideal. Age range anywhere, the youngest has been 19 and the oldest being 82. Mean age is 44. I've actually, since we collected this, I've had 2 young men, 16 years of age, who were participating in this program. Interesting cases. A few more men than women, but pretty much equal. And we measure progress, how they're doing with what's called the brief pain inventory. If you're not familiar with the brief pain inventory, it's a very, very easy to use, validated, reliable scoring tool for assessing how pain treatment is working. It's useful in the context of pain as a multifaceted experience. That's why we use it, because it doesn't just look at how's your lower back, how's your headache, it asks a lot of questions. And it's very well suited to studying pain in patients that have a substance use disorder. But it's a snapshot assessment, we do it at various intervals in their treatment. So this is a copy of one of the versions of it. Now we've taken out the diagrams because we don't want people to concentrate necessarily just on the physical aspect, and we've put some of these things together. So for the patients that we've collected complete data sets, there were statistically significant improvements in all 11 items on the brief pain inventory between the time they come in and started with us and the time they left. And we're doing some follow-up long-term on these people. The greatest difference was in the item on the BPI. In the past 24 hours, how much has your pain interfered with your enjoyment of life? And to me, that's the goal. If they can still live and have some enjoyment of it with pain, then they're going to do okay, right? None of these patients needed opioids. We're not. I don't prohibit opioids. If somebody actually needs opioids to get adequate pain relief, I will let them do it. I will use buprenorphine. I will not use a full agonist opioid. But none of these patients needed it once we brought all this stuff to bear. So, my conclusion is that we have no data suggesting that these opioids are beneficial for chronic pain. And I've got data from the center where I work saying that none of the patients that I treat need it. So maybe I'm a heretic, and that's okay. I don't mind being a heretic, but I'm just saying this is possible. And for people who have a substance use disorder, we can get them adequate pain relief and a good life without being on these medications. So this is our treatment approach at Cairn. And I'm just as grateful as I can be to have all this stuff at my disposal. I know that not everybody who treats chronic pain addiction has all this stuff at their disposal. You know, we should, as a group of addiction professionals, we should be hounding our, you know, Congress people and all the people who are in charge and saying this is what people need, not another formulation of oxycodone that's a little bit safer. This is what people need. And, you know, eventually, I keep hearing little bits and pieces of information suggesting that somebody is listening to this, but it's not happening as fast as we would like. So with that, thank you so much for your attention. I'll be happy to answer questions.